Hello, I'm A.J.Kanellopoulos, an eye surgeon based in Athens, Greece, and New York City, New York. We started using collagen cross-linking in 2002, and we found early on, as the Dresden and Zurich group, that it's a very effective way of stabilizing cornea ectasia, both in keratoconus and post-LASIK ectasia, and we have published and presented extensively on this issue over the last 10 years. One of the difficulties, though, intrinsic in younger Greek patients that we had treated with collagen cross-linking is the fact that although their ectasia is stabilized, we do have still a difficult management issue with how do we rehabilitate these eyes. Rigid contact lens use in this country is extremely difficult due to extreme sand, particulates in the atmosphere, and probably some intrinsic allergic component to Greek patients. So having a second solution after collagen cross-linking was very common. We introduced back in 2005 the use of a partial topographic-guided treatment after collagen cross-linking after we had established that the eye is stable. But after doing several cases of cross-linking first and topography-guided normalization later, we introduced the concept of using both techniques in the same setting. So a partial topography-guided PRK combined with collagen cross-linking. Through the years, the technique evolved to a higher fluence on the UV device. So we are now using 10 milliwatts for 10 minutes on the UV device. And you'll see here the, for us, state-of-the-art technique of using the Alcon Wavelight EX500 laser through a placido disc topographer, the Vario, or a tomographer, the Pentacam 2, which in Wavelight terms is called the Oculizer 2, in order to do a topography-guided normalization of the cornea, limiting at 50 microns the maximum tissue to be removed from the minimum thickness of the cornea, and then collagen cross-linking with the use of 0.1% riboflavin, not diluted in dextrose, but sodium phosphate riboflavin, so a less viscous riboflavin. This is the core of the technique, and I'll run you through some specifics on a very interesting case trying to better elucidate and color for you our routine technique. I'd like to add that we have performed over 1,000 of these techniques over the last 6 years, and that we have reduced the number of penetrating keratoplasties in young keratoconic patients in Greece by a magnitude of almost 90%. And this is the most impressive thing about this approach, the fact that we have stable corneas and patients are seeing better. I hope you find this presentation interesting, and I thank you very much for your attention. So this is our laser platform, the magnificent Alcon refractive suite on the left, the FS200 femto. We'll be not talking about that. And the EX500 excimer laser has the ability to include several options of topography-guided treatments. This is the Athens Protocol in review, PTK, topo-guided PRK, mitomycin C, and cross-linking. Here is a slide showing that UV absorption is done by Bowman's membrane as well. And this is the PTK treatment plan, 50 microns, 6.5 millimeter diameter. And this is the topography-guided partial PRK. Please note here that we have centrally a partial myopic PRK and peripherally a partial hyperopic PRK. We're ready to start the PTK. You can see the mode up on your right, and the EX500 excimer laser is extremely fast in removing the epithelium. And we do this in order to use the epithelium as a mask for the potential regularity of the stromal bed after the epithelium is removed. So PTK first, then we're going to go on to the topography-guided partial PRK. We make sure the bed is equally hydrated. You can see in the top right the topography-guided PRK, again a combination myopic and hyperopic treatment seen here with the EX500 excimer laser. We're using topographies from the Vario, which is the new Wavelight placido disc topographer that also includes iris centroid shift data and cyclorotation data. Here, mitomycin C, 0.02 milligrams per ml for 30 seconds. Despite of the cross-linking that will continue, we still feel and have experienced that mitomycin C helps with some scarring that can be noted in these patients. So a full 30 seconds of mitomycin C. We will then rinse vigorously with chilled BSS in order to remove the excess and make sure that there is some cooling of the cornea. And this is the BSS that will be followed by 0.1% riboflavin, sodium phosphate seen here. We, for years, have introduced this dilution of riboflavin and not the dextran. This is slightly hypotonic, 340 milliosmoles, and we pre-treat just for 5 minutes. So we sway away from the Dresden protocol. 5 minutes of pre-treatment with 0.1% riboflavin sodium phosphate, and then move over to use, as you can see here, a few more drops of riboflavin, the Avedro KXL device, which will fit right between the two lasers of the refractive suite. And this is a highly customized tool. It can provide fluence from 3 milliwatts all the way up to 45 milliwatts. For the Athens protocol, we use a standard of 10 milliwatts for 10 minutes. And this is the device. It's relatively easy to use. 10 milliwatts for 10 minutes. We use riboflavin drops every 1 minute for this 10-minute duration. And here you can see the comparative results of doing cross-linking first and laser later to the combine. And here, topometric images before and after. You can see the dramatic improvement, almost normalization of these corneas. Some Salzmann-like healing issues the first few weeks in some patients. As you can see here, they require vigorous lubrication. And again here, the key element is before on the left, after on the right, and the dramatic improvement in the index of height decentration on all of these examples. You will see examples, for instance, here where the irregularity is normalized, but myopia is induced. And again, the key element here is not refractive error, but improvement, as you can see here, of best corrected visual acuity. Great safety on the results so far. And again here, 15-year-old before and after with excellent result. So in conclusion, we see a very predictable best spectacle corrected improvement, although there might be some myopia induction. And I thank you very much for your attention.